Now, you've got a phase 2 study here. You're looking at subtype. Now, this is the genetic variant and the impact it has on outcomes. Is it outcomes in urothelial cancer?
That's correct. We use the term subtype rather loosely, more as a description of the breakdown of bladder cancer. We draw the names from breast cancer data that was presented from the TCGA, where they tried to classify breast cancer into different groups. And bladder cancer, we've also found, can be classified into 3 different groups. The basal subgroup, which seems to be the most chemosensitive, the luminal subgroup, where we see more FGF receptor mutations, and then a group that has more stromal factors and stromal infiltration that we're calling P53-like.
Okay, now how easy is it to do an assay for basal subtype when you've got a patient with a urothelial cancer?
Well, at the moment, there's no CLIA approved test, so that's going to be one of the next things we do with this work on trying to get a CLIA approved test to help us predict which patients fall into which subgroup. If you look at all of the advances in cancer that have been done, for instance, leukemias and lymphomas, they've all been predated by our ability to differentiate the tumors into different classes that respond to one therapy or another. And the use of subtyping, we're finding, is providing that basic scaffold where we can build on it and predict which tumors respond to which treatments.
So all of these cancers may look the same, but they're not the same.
That is correct. Currently, the thinking is bladder cancer is all one disease, but with the use of the subtyping, we think it's at least 3 diseases, but probably many more.
Right. Run me through what you did in the study to reach this conclusion then.
Sure. Well, we had a 60-patient clinical trial of DDMVAC with bevacizumab, and we found that this combination was quite active. It had very high response rates and a very high survival in patients treated with neoadjuvant chemotherapy. Now, unfortunately, we weren't able to find a definite benefit with the addition of bevacizumab, and that's why we started looking at the subtyping. For instance, when we look at bladder subtyping, the basal subgroup also tends to have increased markers of HIF-1 alpha and angiogenic pathways, including VEGF. So one of our hypotheses is that the basal subtype would be more sensitive to treatment with an anti-angiogenic drug.
And what did you find, in fact?
Well, we tried to compare our data to a previously treated group of patients treated with MVAC alone. And when we look at the long-term outcomes, patients in the basal subtype treated with the angiogenesis inhibitor had a 5-year survival of around 91%. With the use of MVAC alone, it's around 77%. Unfortunately, these results don't achieve statistical significance, but I do think it's worthwhile studying these in larger groups of patients and larger trials that are currently ongoing using angiogenesis inhibitors.
Now, I do believe you have a kind of general comment to make about the use of variants, looking for different subtypes in urothelial cancers, but perhaps also in other cancers.
Well, it's interesting. We see a lot of the same biology in urothelial cancers as we've seen with breast cancer. Again, some of the earliest subtyping data did come from the breast cancer TCGA array data, and where they called them basal subtypes, and the basal subtype was the most chemosensitive, much like we're seeing the basal subtype of bladder cancer being the most chemosensitive. In addition, there's luminal subtypes of breast cancer associated with different estrogen receptor and other cell surface markers. And again, in the luminal subtype of bladder cancer, we're seeing other cell surface markers like FGF receptor 3.
It all sounds very hopeful for individualizing therapy. What do you advise doctors to be doing about this?
Well, at the moment, there's nothing we can do as of yet, but as we start to get CLIA-approved tests, we're going to be able to differentiate bladder cancer into more chemosensitive and chemo-resistant cohorts and develop personalized therapy where we can use that basic scaffold of the subtype to find out which pathways might be upregulated. For instance, a luminal subtype may be enriched for patients with FGF receptor 3 mutations, and those patients may benefit from FGF receptor 3 trials.
So the simple, hopeful message for doctors is what?
We're really on the path toward individualized patient therapy, and this is just one of the methods we're using to better understand the biology behind bladder cancer.